Welcome to today's webinar, Spinal Fusion Techniques. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we'll share a link to where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in planning our educational resources. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick it off, I'd like to introduce our host. Joining us today is Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services, MLCC, a registered nurse and certified rehabilitation nurse, case manager, nurse life care planner, and legal nurse consultant. She has worked as a nursing professional for 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the CNLCP Certification Board. She is also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. At this time, I'll pass it to Cindy Borbo.
Thank you so much. Before I hand this over, I'd like to share a little bit about the Injury Insight program. Injury Insight is a 4-part webinar series that is designed to educate claims professionals, HR resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation. This program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you all better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So get your questions ready for Dr. Aidlen. So for this session, the third of this year, Spinal Fusion Techniques, we're pleased to have Dr. Jessica Aidlen. And I've worked with Dr. Aidlen for many years, so I'm very excited that she's here with us today. Dr. Aidlen is a board-certified orthopedic spine surgeon. She earned her medical degree from the University of Buffalo School of Medicine. She completed her residency in orthopedic surgery at UMass Medical Center and her fellowship in spine surgery at Brown, Rhode Island Hospital. Dr. Aidlen is currently the Chief of Spine Surgery at Newton-Wellesley Hospital, Associate Chair of the Orthopedic Surgery Department at Newton-Wellesley Hospital, and Spine Consultant for Boston College Athletics. He's the Medical Director for the Spine Center at Newton-Wellesley Hospital. Dr. Aidlen is an Assistant Professor of Orthopedic Surgery at Tufts School of Medicine and is active with clinical research and teaching. She is the founder of Reactivate Your Spine, a holistic spine care initiative, which I'm very interested in hearing more about and excited about. Her clinical interests include minimally invasive spine surgery, cervical disc arthroplasty and motion preservation, disc herniation, spinal stenosis, cervical myelopathy, and spine injuries in sports. So thank you again, Dr. Aidlen, for being here, and I'll let you take over now. So I apologize, during the beginning of this program, there were some technical difficulties. So I am going to read Dr. Aidlen's slides for 2 slides, and then we'll have her click back into the program. So back injury stats. Only 8 to 15% of back injuries result from direct trauma to spine, such as falls, etc. More than 1 million back injuries are sustained in the workplace annually. Strains and sprains are most common back injuries, and 2 episodes of significant back pain in 1 year increases the risk of reoccurrence within 12 months. And another fascinating fact is that 1 in 5 workplace injuries are also back-related. U.S. companies lose approximately $225 billion each year as a result of back pain or injury. 95% recover within a few months, and 5% do not and go on to develop a chronic and debilitating condition. So who are my patients? So as you can see from the screen, there's a multitude of people in all different areas and walks of life. Sports, people who are trying to stay fit, the elderly, so back injuries happen to many people, and treatment varies accordingly.
You know, nursing have high rates of neck and back injuries due to lifting patients and things like that. So healthcare workers are actually one of the most common groups that we see back injuries in. So, you know, the current landscape now, I think back pain and spinal surgery and spine care is just such a confusing place in our healthcare system. It costs a lot of money. There's, you know, if you look at spine surgery studies, really the number of level 1 studies and really good data is lacking. And so, you know, when someone has back pain or comes into my office with back pain, this is kind of what they're looking at. It's like, what am I supposed to do next? Which door am I supposed to go into? And, you know, just a little plug for kind of how we do things. You know, it's really important to try to navigate the patients through that episode of care, because again, most patients will get better with conservative treatment, but we want to make sure that that gets done in a timely fashion, and also in an organized, coordinated way. And so, you know, people may go to physical therapy, they may see a chiropractor, they may do acupuncture, they may do injections, they may have surgery, they may have, you know, medication. So there are all sorts of different avenues for treatment, and it's really important to guide patients through to hopefully avoid surgery, and you know, try to get them better and back to work. So, you know, conservative treatment measures for lower back pain, you know, like I said before, medications, PT, injections, bracing, acupuncture, you know, there are a lot of different things that we use to try to settle these acute episodes for patients so they can get back to function and back to life. But you know, the big challenge is that a lot of times people come in and they have you know, acute pain that can be chronic, or sorry, acute on chronic pain. So this pain can manifest on top of a chronic or pre-existing degenerative condition. So it's really hard to tease out, you know, what came first, the chicken or the egg, and, you know, what is the challenge there with treating these patients? Because most of them don't come in with a perfect looking spine and, you know, a lumbar strain on top of that. So it's very difficult to tease some of this out. Excuse me. So I just want to show a case first. So I'll go through this MRI because I know a lot of folks on the call probably don't read spine MRIs every day, but I'll just show you the general gist here. So this is a 62-year-old postal worker with chronic back pain, you know, but able to function and work, and, you know, just has some chronic discomfort and stiffness, etc. And comes in after a work injury with acute severe leg pain and numbness. So on the left side of the screen here, you can see this is a view of the lumbar spine from the side. So we're looking at the vertebrae that stack on one another. So the patient's abdomen is up here and the back is here. And you can see this degenerative L5-S1 disc that's very collapsed down compared to these, nice, healthy, plump discs up here. And then right in the middle here where all the bright fluid is, that's the spinal canal with the cerebrospinal fluid. So that, kind of indicates all the space that these nerves have to sort of swim around in here. And that's a good thing to see. But as you get down here, you see something going on right at this L4, L5 level. And so this is actually a degenerative cyst coming off of the facet joint in the back of the spine. So, this is a patient who has never had an MRI, has had some low back pain and now has these severe worsening symptoms. And you look here and there's a lot of degenerative stuff happening. So degenerative disc at L5-S1, if you look at this view on the right side, this is basically cutting through the lumbar spine in slices, so a cross-sectional view. And these bright white lines right here, that represents fluid in these facet joints. So that means that there's instability in the spine. And also you can see this big cyst here, basically in the spinal canal and kind of squishing all these nerves. And you can see that there on the sagittal view. So, this is what we see. We see these patients come in with these acute injuries, but they already have, underlying stuff going on. And so we sort of have to make a plan as to what the structural problems are and whether or not it makes sense to, do a prolonged conservative treatment or to think about really being more aggressive with definitive treatment for these patients. So I want everyone to remember that case. And certainly when I do tell patients, this is a problem that's, you have instability, you've got these chronic degenerative issues, you have, nerve compression, this is the way they look at me. They say, I don't want anything to do with this. I don't want a spinal fusion. And it's a very scary prospect for a lot of people, understandably. So I just want to kind of talk through, how we think about, when to operate on patients and do lumbar fusions and why and how. And I love this quote by Albert Einstein because spine in general, spine care, spine surgery is really evolving, and it has been, exploding in the way of technology and just advancements in spine care that will try to get patients back to function quicker. So, as Albert Einstein said, if you always do what you always did, you will always get what you always got. So we want to try to think about things differently because, we know that there's a lot of patients who are walking around with, quote unquote, failed back syndrome and chronic pain after spinal fusion surgery and, less than optimal outcome. So why is that? And what do we need to do to kind of approach the way we treat patients in a different way? So just a little bit of a historical perspective. This is more for entertainment purposes and also just interesting to see, how things have evolved. So Hippocrates always said, look well to the spine for the cause of disease. So, in my world, I think that, we see structural problems in the spine, but we also see a lot of chronic pain that can be very complex and be related to, psychosocial stressors, core weakness, poor nutrition. There's a lot of things that can create low back pain. And it doesn't mean that, most of those patients do not need a spinal fusion, and we need to really get to the root cause and not just jump to doing a fusion. So that's kind of my approach with people. And could you imagine, living so long ago, and this is the contraption you were put in to try to stabilize your spine and straighten things out if you had a scoliosis or a curvature or something. So it's pretty barbaric, actually. And so the evolution of spinal surgery, in the early 1900s, a lot of people had deformities from tuberculosis and all of these things. So, physicians were trying to figure out how can we stabilize these deformed, unstable spines. And so, initially there were, bone grafting and wiring techniques. And over the years, we've developed screws and rods and cages. And we went from open surgery down to less invasive surgery with computer navigation and robotics. So I'll go through some of that, but the evolution has really been quite remarkable for patients who do need spinal fusion. So, this is really the key piece of this talk, because I think it's so important to really think about what are the indications for a fusion. And I say to my patients all the time, I'm sure Cindy's heard me say this, you know, in the office as well. I always say to patients, like, I am treating you, not your pictures. So, you know, I really need to know what that patient does day to day. What are their symptoms? What are their physical exam findings? What is their job? You know, do they live alone? Do they have, you know, social support? All of these types of things. Because, you know, if you look here, you know, both of these patients had a spinal fusion. Tiger Woods over here had a 2-level fusion, and he's obviously putting a lot more stress and torque and, you know, high level demand on his spine. Versus this patient over here who, you know, just kind of walks to her mailbox and, you know, goes out to lunch with her friends and just really wants to be, you know, be in less pain. So the way that I treat these patients may be very different, but they might still both be getting spinal fusions. The other thing too is that, you know, medical comorbidities and bone health has been a real challenge, I think, in orthopedics and spine surgery. I see a lot of patients with untreated osteoporosis, and you know, that can really set patients up for failure with spinal fusions. And so we really, again, want to think about what all the aspects of that person's overall health when we think about whether or not they're a candidate for a fusion. And you know, really, I want to think about, what am I trying to accomplish? What are the goals of the surgery? What is the best approach? Can I do a minimally invasive procedure? Not everyone is a candidate for a minimally invasive surgery, but if I can do that, I will. And that's really to try to, you know, preserve soft tissues and get people, you know, back on their feet a little quicker. So, you know, essentially the 3 main goals or indications with any lumbar fusion. So number 1, instability. So if a patient has a grossly unstable spine, then, you know, it makes sense that stabilizing their spine and doing a fusion would help the problem. We see patients with deformity, and when I say deformity, I could mean scoliosis, it could be a degenerative scoliosis, it could actually be a flat back type deformity syndrome where the spine and the pelvis aren't aligned very well. So we need to actually, you know, recreate that normal balance for the patient, because then their function will be better and they can actually have a lot less pain when they're doing their day-to-day activities. And, you know, probably most importantly, all of these surgeries, whether patients are getting a fusion or not, decompressing the nerves is key. So, you know, I always say to patients as well, I'm a spine surgeon, but I operate on leg pain, not back pain. So if someone comes in with just axial back pain, it can be very challenging to have an extremely successful result by just doing a fusion for their back pain. So I really think that the patients who do better with surgery are those that have more, you know, nerve pain and radicular symptoms, because once you get rid of the radicular pain, you know, they do much better, and getting rid of that pain is much more predictable as far as outcomes are concerned. So just something to think about. A lot of times we can obviously treat back pain and significantly improve back pain, especially if someone has true instability, or like a 1-level degenerative disc, and they've done all of the things as far as their whole health otherwise to try to help themselves. Then a fusion for back pain can be successful, but I am very cautious about operating on patients with just back pain. So the goals of any surgery, really, we want to improve their pain and function. We want to get an adequate decompression. We want a stable construct. We want to achieve a solid fusion. So, you know, when we see patients who smoke a pack a day, I really advise strongly against a fusion if they are smoking cigarettes, because that can decrease the blood supply to the bone, and the non-union rates for smokers is very high. Same with patients who are uncontrolled diabetics. You know, morbid obesity can really affect biomechanics of the spine. So all of these things can increase patients' risk for complications. And I strongly advise that those patients, you know, modify, you know, those are modifiable risk factors. And I strongly advise that patients take care of those things before they have a fusion. We also want them to have durable construct. So if they're going to have a fusion, we want to know that it's going to last and they're going to have long-term good function and be able to go back to work. So this is just a cartoon kind of showing the evolution of how we do spine surgery. And some patients do need this traditional open posterior technique. So essentially this is making an incision right along the midline of the spine. You know, we get down to the subcutaneous tissues and to the fascial layer that's over the muscles of the spine. And essentially what we do, if you look on the right side here, we put these retractors in and we really split the muscles. We you know, can disrupt the blood supply to the muscles. There's a lot of soft tissue disruption that can occur when you do this traditional open posterior technique. Now, again, some patients just need this because we need to, you know, directly visualize what we're doing. We need to do deformity corrections, all of those things. But it is a more morbid procedure when we think about soft tissue disruption. And so here's just a picture. So this is really the evolution. This is on the left side, what I was just talking about, that kind of big open procedure where we can see the whole spine. I mean, these muscles are retracted all the way from side to side. You can see the screws and rods that are placed right here. And now, you know, we've got computer navigation, robotics, different ways. Even with these deformity surgeries, we can do some of them through these like small incisions here where we're using cameras and intraoperative CT scans and things like that. So you can imagine that, you know, using these instruments, we can make these small incisions versus this big incision here, which if it were me, I would think this was probably an easier way of recovering. So I personally try to think through those things and incorporate minimally invasive techniques if I can. So, you know, that really begs the question, how can we do it better? How can we think about even these bigger surgeries to do a deformity correction or put in, you know, multi-level hardware and do a fusion through less invasive incisions? And I know that I really want to focus on lumbar fusion for this talk because I think it's one of the most common things we do, but I just want to kind of touch on this briefly. When we think about less invasive spine surgery, you know, we can do just regular decompressions, discectomies, laminectomies with less invasive techniques. There's endoscopic techniques, you know, tube retractors that we use, so we can really minimize the cutting and splitting of muscles and tissue. The other thing that we and I do a lot of is motion preserving cervical disc replacement. So you can do lumbar disc replacements too. I think we have moved away a little bit from doing lumbar disc replacements as much in the US. If you're in Europe, you still may see that a little bit more. But the biomechanics of the lumbar spine are different. And so sometimes the failure rates can be higher with lumbar motion preserving disc replacements. But if you look at this, this picture of this implant here, this is a cervical disc replacement where there's these two metal plates sit on the vertebrae and they have these teeth that help to fix into the bone. And then there's this middle plastic piece which allows for flexion, extension, and cervical rotation, you know, in the normal kinematics of the spine. So helps to preserve motion, prevent adjacent level, you know, degenerative problems, you know, at the level above or below. So it is extremely successful, and the best thing is that the downtime is pretty minimal. Like patients can get back to work and sports and all of these things really quickly. And so, you know, when it comes to lumbar fusion, now we're thinking about specifically how can we do those surgeries in a less invasive way. And there are ways to approach the spine from the front, from the side, from the back. So we can really think about these things in a 360-degree manner. And then this is just a quick picture of the cervical disc replacement. So if you see on this right-sided picture here, that's what that little metal implant that I was showing you on the last slide. This is what it looks like on the X-ray after surgery, versus these here where you have screws and a plate and bone graft replacing the disc there. These are standalone cages. So these are fusion devices that, you know, fixate screws into the bone and, you know, stop the motion versus this that preserves motion. Okay, so let's start with the different types of lumbar fusion techniques. And one of my favorite go-to procedures is called a lateral spinal fusion. And essentially, if you look at this anatomical cartoon here, this up here, can you guys see my arrow moving okay? Hopefully, yes. This is the abdomen up here. This is the back here. So this patient is actually lying on their side under anesthesia, and I make a small incision just on their flank, kind of right below their rib cage, and I put this retractor in here, and I can actually get down to the spine, you know, not affecting any of their abdominal contents, right in front of the spinal muscles here, and we can get right down onto the spine to be able to instrument the to remove the disc and instrument the spine. And so this has been a remarkable advancement, actually, for the way we do lesson. So if you look at these x-rays here, so this is a gentleman who has overall a pretty good looking spine. So you see the vertebrae stacking on one another here. There's a huge space for the nice plump disc below. There's a nice good disc space above, down here. So most of his disc spaces are actually quite healthy. But this one here, you can see it's really almost bone on bone collapsed. That disc is dried out. There's big bone spurs here. There's even a little bit of what we call an anterolisthesis, or a slippage of the vertebrae, one on top of the other. And so what I did was I essentially put this retractor in from the side here, and I was able to put in this big spacer and jack open that disc space there. And this is a titanium cage that's filled with bone graft. And I can, you know, it essentially sits right into that disc space, and you can see on the side view here where that disc space is nice and jacked open compared to what it was before. And so once I do the lateral part of the procedure, then I can put the screws and rods in from the back percutaneously, so just with small stab incisions, using computer navigation. So this patient literally went home with 3 like 1-inch incisions. And I was able to do this fusion and stabilize the spine. And so he had nerve pain. So I don't know if you can appreciate this here, but this area right here is the foramen where the nerve is exiting the spine. And you can see here where it's very closed down. And then post-operatively, you can see where that nerve channel is nice and open up again. And, you know, it's kind of jacked open again. And so this is what we call an indirect nerve decompression. So I didn't have to touch the nerves, I didn't have to look at the nerves, but I was able to actually decompress his nerves just by, you know, affecting the alignment of the spine and the height of the disc space. So really effective spinal fusion technique that is less invasive and gets patients back to their activities pretty quickly. So what about an anterior fusion? So this is a fusion from the front, so through the abdomen usually, and we can do it directly from the front. There's an incision right below the belly button to kind of get into the spine. You can do a little bit of an oblique view here to get to the spine, and you can see on this cartoon here, so versus the true lateral retractor, now we're kind of coming in from the front here, and we're inserting this spacer you know, from front to back, and we can actually put screws in right from the front. So I love this procedure because, again, it jacks open that disc space. You get good restoration of the disc height. I can put a lot of bone graft in there for the fusion bed. And the best thing is I don't have to disrupt the muscles and the ligaments in the back of the spine to achieve what I want to achieve here. So just a picture here, and this I actually marked out the foramen for you. So, you know, these are the channels for the nerves to exit the spine here. And you can see in this pre-op x-ray, that L5 foramen is really squeezed down tight because the disc is just collapsed. So compared to the other disc spaces here, this L5S1 is really collapsed down. And then after surgery, and it's a little fuzzy on this picture, but there's an ALIF cage here. So again, a titanium cage filled with bone graft. There's screws that fixate into L5 and S1. And now you can see that foramen is nice and expanded, so that nerve is much happier and decompressed. And that relieves leg pain and is a really successful way to achieve this goal. So let's revisit that first case, the one that I showed you guys the MRI with the big fluid-filled facet joints. He was unstable, he had the cyst, he had spinal stenosis. You know, I always have patients, you know, do an injection, do some PT, try to see if we can at least get their symptoms settled a little bit. But at the end of the day, that guy had a structural instability that really needed to be fixed in order for him to have a good outcome. And I'm a big advocate for, you know, while I'm conservative and I think it's always right to do conservative treatments first for symptoms instead of treating the picture, you know, the chances of this guy needing surgery is high based on his gross instability. And so it doesn't make sense to me to have someone like that do conservative treatment for 3 years and then at that point be just so debilitated that they're never going to get back to their activities, they're never going to exercise again, they're never going to work again. So, you know, there are cases where it is actually important to think about the longer term outcome, and is it better to be more aggressive and do surgery earlier to try to get that patient back on her feet. So that gentleman had a minimally invasive fusion surgery here. So you can see where the cage is, and I'll show you some pictures on how I did that in a moment, with these screws that fixate into the vertebrae and the rods that connect the screws to kind of give you that overall stable construct. So the patient has anterior spine column support, posterior spine column support, and the screws fixing there. And so the way that I did this was with a posterior minimally invasive fusion, and it's called a TLIF, which is a Transforaminal Lumbar Interbody Fusion. We like a lot of acronyms and letters in spine surgery. And if you remember that picture that I showed you before, this is the traditional open TLIF where we're using those retractors to really pull apart the muscles so we can get the right angles for the screws and get into the spine. But a minimally invasive TLIF allows us to actually preserve all those muscles and ligaments in the midline, so we don't have to make that incision in the middle of the spine, but instead we can make these smaller stab incisions on, you know, off to the side of the spine, so we're really not retracting and you know, cutting any of those muscles. And in order to do this, we do need you know, good imaging. So you can do it with fluoroscopy or regular x-ray, but that does give a lot of radiation to the surgeon and the staff and the patient. We wear lead in the operating room, but it's something that would require a lot of radiation to do with just a fluoroscope, you know, fluoroscope. So doing CT guided computer navigation and robotics is a really great application for this, because we don't radiate during the surgery. We just use the computer to kind of get real-time information on where our hardware is going. And so we call these technologies enabling and transformative technologies. So they're basically things that we use to enhance our view of the spine through small cameras, small incisions. You know, how can we see the spine inside by not having to, you know, cut everything open and look at it directly? So, you know, the problem is that enabling technology is good and it's necessary, but we have a lot of technologies that add cost, they add time and complexity to the operating room area. So this is, you know, kind of what a lot of these technologies are trying to address. If you look at this operating room here, you can imagine that this becomes very crowded when we have all of these people and this, you know, tower here and this x-ray machine here and the anesthesia machine and all these things. So how do we kind of pare everything down to make sure we can do these fusions in a better way? So there are things out there that we use that are more integrated to enable a better procedure. So it's one slim tower, it's an x-ray machine, and we're able to do a lot of different things using these technologies. And there's a few companies out here who offer this, which has been really nice for us to kind of change the way we do spine surgery. So this is actually a picture of me and my physician assistant in the operating room, and you can see on the right side here, it just doesn't feel crowded. Like we have a lot of instrument trays, and we're putting in screws and rods and cages, but it doesn't feel like we're overcrowded. It's me, my PA, you know, the scrub tech and the student. There's a neuro monitoring person behind that screen. Our C-arm is over here, but we have plenty of room. And this, you can see essentially what I'm doing is, and by the way, other thing I'll point out, I'm not wearing lead. I'm not wearing a headlight. So I can actually, from a surgeon health perspective, am able to, you know, look at a screen. So ergonomically, my own spine is more well aligned. I'm not having a heavy thing on my head. I'm not having a lead apron on. And this can really affect the longevity of the surgeons who are taking care of these patients as well. So that's the good thing. But essentially what I'm doing is this little computer navigated array here is looking at, talking to a camera that's kind of like behind me as if I was taking a picture. And we take a CT scan intraoperatively of the levels we want to instrument, and then I'm able to place screw, like I'm literally putting in the screw and watching it go into the spine on the screen. And you can see that incision is like, it's literally like a half an inch. So it's pretty cool stuff. And then we're able to check the nerve monitoring to make sure that the hardware went in appropriately, it's not too close to the nerves, all of those types of things. So really improves our accuracy. So we all know how to put in freehand screws as spine surgeons. But you know, there's some element of human error as well. And of course, computer navigation is not 100% perfect, but it does improve our accuracy because we can see exactly where, you know, how wide the screw is in the bone. We can measure exactly, we can see it going in real time. So very improved accuracy. And then nerve monitoring during the surgery. So this increases patient safety as well. So I put in that screw, and then I basically put a probe on the screw to check the level to see if it's close to a nerve. So, you know, this gives me real-time feedback. So if it's green, it means it's a safe zone. So you know, there's nothing near the nerve is fine. If it's 4.5, like then I know I either need to, you know, reposition the screw or take a look and see what's going on there. So real-time feedback, so it's safer and we can address issues if they do come up in the operating room instead of figuring it out when the patient's, you know, in the hospital the next day and still having bad leg pain and realizing that we have to go back and change something. The other thing that a lot of this technology does is that we actually can bend rods using the computer. So we can correct deformity, we can increase efficiency in the operating room. So it's not me like using this big rod bender and trying to figure out how to make it perfect or make it look, you know, sort of similar to what we want it to look like. We can get it very exact, and the rod will drop into the screws and we can connect everything together. It's a really beautiful sort of workflow that we can have with this technology. So it's pretty fun. And lastly, we can look at spinal pelvic measurements during the surgery so we can get optimal alignment and correction. So a lot of times these fusions we're doing, we actually need to increase lumbar lordosis, say, so that normal curvature in the lower back. We want to basically get that spine back into normal alignment because we know now with all of the data that we have in spine surgery and deformity surgery that patients do better overall and longer term if they have adequate balanced spinal alignment. So they have decreased risks of adjacent level problems above or below their fusion. They have decreased risks of further surgery. They have decreased risks of junctional kyphosis, which means their spine kind of falls forward above their fusion. So if we can get them back in a normal balance, the chances of them having a good long-term outcome and decreased back pain is high. And so here, this is sort of, you see the green spine here is nice harmony. It's like that S-shaped curve with the lordosis and the thoracic kyphosis compensating. The yellow is sort of like the patient's starting to get some degenerative discs. So there's collapse here and they're starting to have to, you know, rotate their pelvis a little bit to stand up straight and get their day-to-day activities done. And then the red one, this is a very decompensated spine. So it's flat. The patient's pitched forward, it's affecting their hips and their knees. these are the most difficult ones to address. But it just goes to show that your overall spine alignment truly affects your entire musculoskeletal system. And so this is a case that I did all minimally invasive, and it looks like a lot of hardware, but essentially what I did here is I did the lateral cages, so that through that one small incision on the side of the flank, I was able to put in these 3 lateral cages to straighten out the spinal deformity from the front. I'm sorry, from the side. And then I put the patient prone onto their belly, and we put all these screws in and the rods and the cage down here. So this is the final construct. And the patient essentially has one small incision on the side and a couple in the back just to get the rods and screws in. So what about potential late complications with spinal fusions? I think this is one thing, you know, we can look at these beautiful techniques and all this fancy stuff and say, oh, that looks pretty, you know, but really what's going to happen to these patients down the road? I think that's what we worry about. Like, they go back to work, you know, they're a manual labor or whatever they're doing after a 1 or 2 level fusion. What is the chances that they're going to have something happen down the road that needs to be addressed again? So, you know, the late complications that we worry about, hardware loosening or failure, again, I think all of this stuff goes back to general whole person health. So we want to make sure that their bones are healthy enough to handle the hardware. We want to look at their alignment. Like I said, we don't want to have a decompensated spine. If they do have a decompensated spine, we want to get them back into balance. And one of the biggest things that can happen, and we don't know this usually for a year post-op or later, is a non-union or pseudarthrosis. So the best way to look for and diagnose a pseudarthrosis is not on an x-ray. So a lot of times patients come in and the surgeon will say, oh, your fusion looks beautiful, everything looks fused. And you can sort of tell on an x-ray, but if you really want to confirm if the patient's still having pretty significant back pain and you want to, you know, confirm that fusion took well, you want to get a CT scan. And the CAT scan will show us, and you can see here, this is a picture of a non-union. So all of this bone should be you know, incorporated, but it looks really fragmented, and there's really not good bridging of the bone across that disc. And same on this sagittal view here, you can see that black line all the way from front to back, meaning that bone is not fused. And so that can cause chronic pain and issues and would need to be redone if the patient's pretty debilitated. Some patients actually have, you know, pretty asymptomatic non-unions, which is good. And so we don't have to necessarily fix every one of these that we see. But, you know, if they're having symptoms from it, you need to revise it. And this is the problem. This can happen with patients who are smokers, you know, uncontrolled diabetics, things like that. So going back to those modifiable risk factors. And, you know, I always say to my trainees, my residents, my fellows, you really cannot be a one-trick pony when it comes to spinal fusion. So you have to be able to not only evolve in your own practice and your technique. I mean, I was not doing any of this minimally invasive stuff 13 years ago when I started in practice. I did a pretty standard open deformity, you know, fellowship at Brown. But I feel like I was well trained to kind of take spines apart and put them back together. I really understand the anatomy. And so I was able to incorporate and learn and train on these minimally invasive techniques. And now that's basically what I do for the most part. And I'm able to do a lot of these things through the side, through the back, through the front. Like, you got to be able to address the patient's pathology and treat every patient individually, what their pathology is, what the patient is, who they are, what they need. So that's, I think, a really important part of spinal fusion. So how do we optimize outcomes for fusion? So I think really important is the prehab, looking at getting patients stronger, looking at their health, their nutrition, their diabetes management, smoking cessation, all of the stuff in surgery I just talked about. After surgery, early mobility is key, less pain medication. We're doing a lot of studies now looking at opioid prescribing practices and multimodal pain management approaches so we can minimize opioids. I don't put anyone in a brace for the most part because I don't want their core to weaken and depend on the brace. And I just really want people to get back to their activity faster and better. And then the future prevention is key. All of this is basic, you know, health stuff. So bone health, body mechanics, good posture, lifestyle management, core strengthening, psychosocial health, all of those things. And really the goal hopefully is to start doing more of the stuff outpatient and get people back to their life. So the future is bright. We have a lot of platforms and technologies that we can start to, you know, continue to incorporate as we see things happening overall. And this is what I will always preach to everybody. This is really my passion, is looking at functional spine care, looking at all of the modalities to maximize outcomes. So thank you to everyone for this collaboration. It's really an honor and a privilege to do this work. And I think, you know, we're really committed to innovation and advancements in spine care to help patients get back to function and back to work. And that really takes all of us to do so. So I appreciate it. I think I'm just on time, Cindy.
That's perfect. Absolutely perfect. That was great. I'm going to let Samantha keep going.
Okay, thank you, Dr. Aidlen, for sharing so much information about spinal fusion. We ask at this time to please take a moment to complete the scan survey that you should see on your screen. Give me just one moment. Here we go. Does everyone see the scan on your screen? If you could just take a moment to go ahead and share your feedback, it's valuable and helps us in the planning of our educational resources. And we're gonna go ahead and start off with the question and answer session. Please be sure to submit your questions using the Q&A feature within the Zoom dashboard. Let's see, go ahead and wait for some questions to come in. All right, it looks like we have one for you, Dr. Aidlen. I have had patients where one physician has recommended an anterior lumbar approach, and a second opinion MD would come in and recommend an anterior and posterior approach. Why would this happen? What could cause these different opinions?
So that is actually a great question. And, you know, I think it goes, so there's probably a couple of different reasons for that. So one reason, you know, that slide that I showed where there's all of the different approaches and, you know, different ways to do things. Some surgeons are just more comfortable doing anterior versus posterior versus lateral. So, you know, I think that you may get different opinions based on just surgeon comfort level and, you know, what they're used to doing and what is good in their hands. I would say that, you know, sometimes patients get very different opinions on the extent or the invasiveness of the surgery, and they say, well, you need a front plus a back surgery, you need 3 levels versus 1 level. And, you know, I guess a lot of that variability can depend on whether or not the surgeon thinks they need to address like a bigger deformity problem, or if they can do a shorter segment fusion just to treat the level of the nerve compression and the pathology there. And, you know, a lot of this is debatable, and some of the time there's not necessarily a wrong answer. But I will tell you that there may be different opinions, and I would say that the most important thing is making sure that the surgeon really explains why they are recommending that approach over a different approach. So if someone's saying anterior versus anterior posterior or vice versa, you know, I know that there are certain pathologies that we really, you know, the data shows that an anterior posterior is actually better, more stable fixation versus just an anterior alone. It could be related to the patient's bone health, and so maybe one surgeon is really focused on, like, you know, recognizing that, while someone else, you know, just doesn't look at that as much. So the point is that I think it's really important to ask the surgeons questions and make sure that they are really thinking through why they're making that recommendation and giving answers related to that. Hopefully that's helpful.
Okay, it looks like we have another question from a participant. Many patients go to chiropractic for adjustments. You listed this as a treatment. Do you recommend this?
So that's a loaded question. I think just like surgeons, there are better chiropractors than others. And it also depends on what the patient's pathology is. So if they have a cervical disc herniation, they should not be having cervical manipulation. So that I think some of that is pretty cut and dry. If someone has kind of chronic degenerative disc disease and they've got back pain, I don't see it it's not necessarily harmful to go to a chiropractor and get some adjustments. If they have like true instability or something like that, again, that patient may not do well with certain chiropractic treatments. But I think it all goes back to if you're seeing a good chiropractor who's thoughtful and looking at knowing what the problem is and knowing what the patient needs, and kind of matching those things, then it can be a good adjunct to their spine care.
Okay. Looks like another question is, when you go in from the abdomen, can you see everything you need to see regarding nerve impingement?
So again, if we going in through the abdomen to do an anterior interbody fusion, we don't really ever visualize the nerves directly. So it really depends on what their pre-op MRI looks like. So, one of the reasons we may choose to do an anterior approach is because we know that by jacking open that disc space, we can get the foramen or the channel where the nerve exits opened up. That being said, if someone has pretty severe central spinal stenosis, an anterior alone approach may not be enough, and you may direct visualization of the nerves to take pressure off. So we can see what we need to see by removing the disc, and we can see the vertebrae and the bones, but we're not actually directly visualizing the nerves from the front. So that's a good question.
Okay, and it looks like we have time for one more question. Do all hospitals use neural monitoring on the site?
No, I think the neural monitoring piece is variable. There are some institutions that routinely use neural monitoring on every single spine case, even a microdiscectomy, which seems a little over the top in my opinion, but there are other institutions that don't use neural monitoring for even cervical myelopathy. I think, for these types of less invasive approaches, I think it's nice to have as like a second, just a second check or a safety check for the instrumentation. But it's really not like a standard of care, like must use neural monitoring during some of these procedures. So I would say, medico-legally it can a lot of surgeons will do it just because they like having that double, triple check. But it's not absolutely necessary on every spine case.
Okay, Dr. Allen, if you wouldn't mind, just one more question came in at the last minute.
Sure.
Can you do anterior surgery on an obese person?
You can. Well, so anterior surgery, you can. It is very obviously more challenging to do through the abdomen in someone who's obese. I would say the lateral interbody fusion, where the patient's laying on their side, is actually a great application for an obese patient because the abdominal contents tend to kind of fall forward and out of the way. And so we can get that tube retractor in there, to get down to the spine. So the patient's BMI and the body habitus is definitely a factor when we think about, what approach we're going to take and what is the easiest way to access the spine.
Okay.
Can I jump in, Dr. Aidlen, just really
Yes.
quick? For a lateral approach, is there a limit though? Like, is there a limit of 300 pounds or?
So, to be honest, I think any spinal fusion you should have, like we try to recommend a BMI 35 or less. Because we know that BMIs over 35 have less optimal outcomes, particularly BMIs over 40, much higher risk of complications. So I would say regardless of the approach, the patient should try to minimize BMI. And we actually have a good relationship with our weight loss surgery center as well, where we send patients over to do consults with them and potentially consider like gastric sleeves and things like that before they have their fusion. And I will tell you that the patients who do lose weight, surgically or not, do much better.
Right, thank you.
Okay, so that looks like that's all the questions for today. Thank you again for joining our third Injury Insight of 2023. A playback of this webinar will be available within 48 to 72 hours. Additionally, again, like I said, we'd like you to not forget to take that survey. Hopefully everyone had a chance to scan the survey code. I'd also like to remind you of our next session that's happening November 8th. And that one's on practical applications of functional neurology. Thanks so much, everyone.
Thank you.